Hi, everybody. I'm Dr. Michael Hyman. I'm a urologist practicing in Los Angeles here in Encino, and I'm board certified. My practice is mostly geared toward men's health, including erectile dysfunction and testosterone issues, as well as prostate problems. I also take care of kidney stones. You can look at my website, www.drhyman.net, drhyman.net, or you can go to my YouTube channel and check out some other videos. This is basically a part 2 of my discussion of inflatable penile implants or inflatable penile prosthesis. You can check out part 1 for sort of the overview and introduction, and I talk about sort of how it works and the indications for it. This discussion is really some of the more nitty-gritty details about how the operation is actually done, some of the complications that can occur, some of the malfunctions that we see with the implant. So let me just give you a brief overview of how the operation's done. Basically, you're brought into the operating room and, of course, and put under full general anesthesia. So it's not a sedation type of thing. It's full anesthesia, which means you're essentially hooked up to a ventilator for the operation. The first thing we do is a very long antimicrobial prep, because we want it to be as sterile as possible in that genital region. So we use sort of a very strong antibacterial, antimicrobial solution, and we're essentially just sort of cleaning down in the genital area for literally 10 minutes by the clock. We actually time it, because the longer we do that prep, the more we're gonna go from 98% to 99.999% of destruction of any kind of surface organisms that could contaminate and infect the prosthesis or the area where we're operating. So that's step 1, and of course you're getting intravenous antibiotics for the operation as well. So the first step in the operation is making a small little opening or a small little incision. It's really small, okay? So it's like maybe an inch, if not less. And that incision is made sort of right at the base. If this is the top of your penis, this is the bottom of the penis where the urethra is. This is kind of out sticking out of your urethra. We kind of flip it up, and we make the incision across the base of the penis on the underside, right where the scrotum starts. So we call it the penoscrotal junction, and we make what we call a transverse incision, pretty superficially, meaning just through the skin layer. And then once we get underneath the skin, we carefully dissect down. We identify the urethra, which is the tube on the underside of your penis that carries the urine. I usually have a catheter in there, so that the catheter, the stiffness of the catheter, you can move it and feel it at all times and be aware of it, so that you don't injure the urethra. You don't want to, cut into it or injure it. And then I can move it, one way or the other. And then you basically find what we call the tunica albuginea, which is the sheath surrounding each corporal body. Those corporal bodies are contain this kind of spongy tissue that engorges with blood when you get an erection, but unfortunately become dysfunctional, let's call it. They either aren't carrying the blood, or they become scarred or atrophic, or essentially non-functional. They're no longer engorging with blood, and that's why you're doing this implant. So then what happens is, once that's identified, we make a little incision in that tunica albuginea, very small. That incision is maybe 1/4 of an inch. Not much more, maybe 3/4 of an inch. And then what happens is, after that, we essentially have to dilate, or essentially create a space inside those corporal bodies. We create a space, and in so doing, we basically, for the most part, we're not actually taking out the original corporal tissue, that spongy tissue. We're leaving it there, but it's getting all compressed, and for better or worse, it's getting essentially destroyed, because you have to make room for the implant. That's why I said in my last video, you can't go back. You can't put this thing in, and then if you're like, I think I want to take it out and go back to the way I had it, that isn't going to happen. No way. So we're basically getting rid of that tissue, and we're replacing it with these implants. There's one that I used before in my last video. This one's inflated, so and again, it's a sample, so it actually gets even more rigid than this. And so it's deflated, of course, when we put it in. So we put one in on each side, one of these cylinders on each side, and they travel the length of your penis. And then the next step of the operation is, and sometimes we do these in sort of kind of simultaneously, in a sense that sometimes we'll get the corpora, those spongy tissue areas, ready for these cylinders to go in, and then while we're waiting for the nurse to prepare the cylinders to pass on to the operating table, we'll prepare the space to put in the reservoir. So what we'll do in that case is either use a little pocket that we can create through that pinoscrotal incision. We can kind of use our finger and tunnel underneath and deep up through the groin. You know how like doctors will sometimes feel for a hernia? Well, we can actually push our finger up in a similar manner through that little incision, reach up to where the doctor would feel for a hernia, and you can actually enter into the space next to your bladder through that same, what's called the external inguinal ring. And you can pop into that space and make a small little opening. And through that small little opening, we can then put this reservoir through there, and it lays next to the bladder. And then the final step is to make a small little space in the scrotum. Again, through that same pinoscrotal incision, we can make a little space in the scrotum, sort of superficially, so in front of your testicles, in front of them, right under the skin there, and then we just slide this pump inside that space, and that's basically it. And then everything gets closed up very carefully. We use tons of antibiotic irrigations and solutions during the procedure because we want to be as careful as possible to prevent infection. We change gloves a lot because even though we're completely sterile for the operation, we can imagine that, if there's some blood on our fingers at some point, maybe something in the air can, even though there's ventilation systems pulling all the air out in these operating rooms, they're very sophisticated, but we just go extra steps and we take off our gloves and replace them with fresh gloves. We use a special lining on your body, almost like this sticky saran wrap, so that, we go extra length to keep this operating field sterile. So that is, in a nutshell, how the operation's done. I always leave a drain at the end. So usually if I went up the left groin to put in that reservoir, I'll go into the right groin, and then you'll see a little tubing coming out through the skin at the top of the groin, and then a little, kind of looks like a little grenade type. We call it a grenade. It's like a clear plastic spherical type thing that we compress so it can create suction, and then it draws any extra fluid out of the operating area that we had been working on. So that stays in typically one night, sometimes a couple of nights, rarely 3 nights. But that's a really good thing to do, if you ask me, because in the old days, if we didn't do that, there'd be just so much more swelling in the penis and in the scrotum, and that's what really causes a lot of the pain. I have found that when we put these drains in, the level of pain is just way down now. People have much less pain after the operation, so the drain's a really good thing. And then usually I have it all wrapped up in what I call like a mummy gauze. So you're just having like this kind of wrapping gauze around the scrotum and around the penis, kind of keeps everything pushed up, and that's all stays around overnight, all in place. And you usually have a catheter overnight. And the catheter sounds horrible, but honestly, once it's in, which goes in while you're asleep, you really don't even know it's there. When you wake up, it's draining your bladder continuously, and so that way we can just, you don't have to get up and urinate during the night. And then that comes out, it just slips right out in the morning. It's not painful when it's really, it really isn't. It's like a little bit of a pinch, nothing more. And then we unravel the bandage in the morning. And so when I send people home, 98%, they go home with no bandage, maybe a little sort of 2-inch by 2-inch gauze where the little tiny incision is, and that's about it. So that's basically the operation. Complications, they're rare, they really are, but you should be aware of them. One is vascular, okay, so obviously bleeding. I mean, that's really any surgery pretty much can cause bleeding. The big issue I would say as far as bleeding is when we put that reservoir in, sometimes you can injure one of the large vessels in your pelvis, called iliac vessels. Fortunately, can't say I've ever seen that happen myself, but it's been reported, and if that were to happen, it would be a very big deal. It would generally require us to consult a vascular surgeon to come into the operating room and help repair that. Another complication that can occur is an injury to one of the urinary tract structures. Okay, so the urethra, for example, which is coursing through the penis, and we're right there next to that urethra. So as we're operating, it's possible to injure that urethra. And very rarely that could result in aborting the operation. I mean, that's rare, but possible, because if the urethra is injured significantly such that we've entered it and we're worried that, bacteria in that structure could contaminate the field, we might say, you know what, we better stop because this is too high risk for infection. Sometimes we can put little sort of like almost placeholders in those corpora, and then go back after we're comfortable that things are sterile enough and the urethra is healed up enough that we can go back and finish the operation. Again, can't say that I've seen that myself, but that's been reported. And then the corporal bodies themselves, so they can get injured. In other words, when you are preparing them to put in these cylinders, you have to use these, they're called dilators, which are, these kind of metal rods that have to create that space. And sometimes you can, cause an opening in that tunica albuginea, that sheath surrounding that spongy tissue. Usually that isn't a major problem because we can just redirect, get it in the right space, put these cylinders in, and it'll just heal right around the cylinders. The important thing is to recognize that this little opening has occurred, because if it's not recognized, then you're going to put one of these in and it's going to pop out through that opening, and you're going to have a problem with inflating it because it's not going to be straight and it's not going to look right. Again, can't say I've experienced that in my own practice, but it would be unfortunate. You would for sure need to have that repaired, but it is absolutely repairable, just something you need to know about, that these things can happen. The prosthesis itself, as I said in my last video, has gone through a tremendous evolution in terms of its design. It's the same concept. It's these three components: the pump, the cylinders, and the reservoir. And I went through this in my last video. What's become really, really more sophisticated, things like the pump itself. We used to encounter something called auto-inflation, where you put the reservoir in, and if the reservoir, all these structures, all these artificial components, they encapsulate. The body forms a little capsule around it, and if it forms a capsule around this and it's too tight, then the reservoir won't fill up. So what if the reservoir doesn't fill up? Then these stay inflated. So, in the old days, people would complain that they couldn't get it to deflate, and they were walking around with an erection all the time because their reservoir was too tight of a capsule or embedded in some scarring. And that was called auto-inflation. But what's happened is they've really these companies have improved the design of the mechanism of this valve, and so really we don't see that nearly like we used to. It doesn't auto-inflate. In other words, it has a lockout. So whereas before, if there was pressure on the reservoir, it would push the fluid through the pump and into the cylinders, but now there's a little automatic lockout so that when you empty the cylinders into the reservoir, it clicks, and then you don't hear this, but it's something engages, and it won't let the fluid go back until you make the first compression on the pump, and that you do feel a slight click, and that's where it opens up the valve, and then it's going in. So that's a pretty cool advance. And then if you look at the tubing itself is now got this little tiny metal coil in it. The junctions are much more reinforced, and so we don't see the kinds of leaks and problems that used to occur decades ago. So the malfunction rate is very low, but still certainly something that needs to be understood and known about. Sometimes the implant doesn't seat exactly right, and so when you're inflated, you can sometimes note that the head of the penis is a little more floppy than you would have liked. And so it's just not going quite as distal as we say. In my last video, I explained the head of the penis does not fill up, and the tips of these corporal structures, the tips of these cylinders go to the base, or kind of like maybe a 20%, 10 to 20% into the head of the penis, but then they stop because the head of the penis is really a different compartment. It's like a spongy compartment. It's not a contained, encapsulated area. And so sometimes because of the scarring that you may have at the ends of your corporal bodies, these can't go far enough. And so it only goes to maybe just below the head of the penis, or right at the level of the head of the penis. And you may notice that the head of the penis doesn't have, quite as much rigidity as you would want it to. You'll still be able to penetrate. That is also not something that happens often, but it is something that can happen even if everything goes perfectly smoothly. So it's a sophisticated operation. This is a sophisticated device, even though it was designed 50 years ago. And as I said, it's only gotten better. But there are a lot of steps to this and a lot of little nuances. And I think it's just important that people are aware of it before they, jump right in and do this. Having said that, and as I discussed in part 1 of this video, it is highly satisfactory. People are extremely happy with this. One of the things they love the most is the fact that they can, of course, get an erection anywhere, anytime, because they just have to pump it up, and it literally takes 20 seconds. So, often people will say I've never had it this good because I've never been able to get an erection without even thinking about it. I can just pump up my penis and away we go. And then the other thing that a lot of people get happy about, including your partner, is that after you have an orgasm, we usually have what's called a latency, a period where we basically lose our erection, and there's like a latency period where we're not able to get an erection again. Most people, at least, for sometimes 30 minutes, an hour. Not so true here. You can have your orgasm, and there is no loss of erection until you bring it down. So if your partner still wants to keep going, so to speak, they can do that, as long as you keep it inflated, and there's really no limit. You can leave it up there, for an hour if you want, or 2 hours or whatever, and then bring it down later on. So those are, pretty much the things I wanted to talk about. As I said in the last video, you can go on my website, and we do telehealth and, of course, in-person consultations. My office is here in Encino. And look forward to meeting you or speaking with you, and have a great day.